Welcome to FSMC Surgery Simplified. Today's question is long essay type of question. Describe etiology, clinical features, and management of indirect inguinal hernia. Etiology of indirect inguinal hernia can be classified as congenital or acquired. Hernia exploits weak areas in the abdominal wall. Inguinal canal allowing descent of testis from retroperitoneum to scrotum is a natural weak passage in the lower anterior abdominal wall. Testicular descent is preceded by a pouch of peritoneum known as processus vaginalis. After birth, this gets obliterated except for tunica vaginalis around the testis. The processus vaginalis may fail to obliterate completely or partly. This facilitates the protrusion of abdominal contents into the inguinal canal, leading to hernia formation. Similarly, in females, the pouch of peritoneum accompanying the round ligament of uterus may fail to obliterate and persist as canal of Nuck. Presence of patent processus vaginalis or the preformed sac in males and the presence of canal of Nuck in females is the basis of congenital theory of indirect inguinal hernia. Additionally, there may be genetic causes of altered collagen metabolism, particularly collagen type 1 and type 3 fibers. There are several examples, most common being ED syndrome. Now let's move on to acquired causes of indirect inguinal hernia. Anything producing sustained increase in intra-abdominal pressure is an important acquired cause. This will force open the preformed sac and weaken the normal defense mechanisms of inguinal canal, thus producing hernia. There are several causes, for example, chronic cough, asthma, COPD, pulmonary tuberculosis, chronic constipation. The most important surgical cause is bowel malignancy, chronic urinary obstruction like BEP, stricture of urethra, etc., ascites, pregnancy, and intra-abdominal tumors, etc. Obesity is an important cause. Not only it increases BMI, but the fat accumulated will separate the muscle fibers, resulting in muscle weakness. Smoking, in addition to increased intra-abdominal pressure due to bronchitis, also alters the collagen metabolism. Thus, smoking is an important acquired cause of collagen deficiency. Currently, there is not much evidence to support the classical teaching of lifting heavy objects or exertion as a precipitating cause. Now let's move on to clinical features. It can occur at any age, usually bimodal. First peak being in neonates, infants, children, and young adults, and then a second peak in later adulthood. Thus, indirect inguinal hernia can occur in any age group. It's more common in males. Though femoral hernia is common in females, indirect inguinal hernia is still the most common hernia, even in females. Remember this tricky question in MCQ. It may be unilateral or bilateral and usually presents as a swelling in the groin, may be asymptomatic except for swelling or local discomfort or pain which may radiate to the upper abdomen. Some of the important clinical signs are as follows. It is pyriform in shape, a positive expansile impulse on coughing. This is the cardinal sign of hernia, but its absence does not exclude hernia. Similarly, all swellings with positive impulse are not hernias. Depending on its extent, it could be complete hernia, reaching bottom of testis, or funicular, reaching top of testis, or bibinocil, confined to inguinal canal. If complete and producing inguinoscrotal swelling, then it is not possible to get above the swelling and thus differentiating it from pure intrascrotal swelling. It can be distinguished from direct inguinal hernia by performing deep ring occlusion test, finger invagination test if permitted by the patient and not discomfortable to him, and Siemens test, etc. Deep ring occlusion test, if performed correctly, is an important test. though there are certain fallacies with this test. Even the most experienced surgeon may not be sure about the exact nature of hernia. It can be confirmed certainly only during surgery. But in practical exam, this is an important test. Learn it properly. In the words, it is a drill for you. Malgaignous bulges are not seen. Depending on the contents, it could be enterocele or omentocele. This can be confirmed by doing appropriate tests. It may be reducible or irreducible. Features of intestinal obstruction may be present, indicating an emergency situation. Now let's move on to the most important aspect of the topic, that is management of indirect inguinal hernia. Surgery is the only curative treatment, but currently watchful waiting is recommended in small and asymptomatic cases, provided the patient is advised properly when to attend the hospital without delay. Trust has no role even in high-risk cases, because these are the very cases which need surgery, and surgery can be done under local anesthesia. There are two situations: emergency cases and elective cases. Management of emergency cases. The principles are as follows. Don't waste time in taxis. Time is crucial. Infarcted bowel is the cause of death. With due resuscitation, immediate surgery is to be performed. If the bowel is viable, it is replaced. If the bowel is not viable, resection anastomosis of the bowel is done. Since the field of operation is contaminated, mesh use is avoided. Though some advocate biological absorbable mesh, best option is to perform simple Bassani's suture repair. Management of elective cases. There are two options. One is open anterior repair with or without mesh. Number 2, posterior repair with mesh using minimal access surgery, usually laparoscopy. Assisted robotic surgery is another option, but highly expensive. Hardly any justification for it in a simple hernia. Open repair methods. Herniatomy is the fundamental step. Then only herniorrhaphy or hernioplasty is to be done. Herniorrhaphy is suture repair to reconstruct the posterior wall of the inguinal canal with available surrounding tissues. Hernioplasty is reinforcing the weak posterior wall with a mesh. Herniorrhaphy. The methods available are: number 1, Bassani's repair. It is still a good procedure if done correctly. Common procedure used in poor resource countries. Number 2, Cherished repair, a popular method using multi-layer overlapping procedure known as double breasting, but needs a lot of training. Number 3, Maloney's repair, consists of darning, a simple procedure, no learning curve. The darn itself acts as a mesh, hence it is a popular method in poor countries. Number 4, Desarda repair, innovative procedure by an Indian surgeon, Desarda. Here an undetached strip of external oblique aponeurosis is used to repair the defect. It is more physiological, dynamic and functional, as against a mesh which is only static, just covering the defect. It is a cheap, tension-free and mesh-free procedure with minimal learning curve. In fact, Desarda repair is an effective rival against mesh repair, be it open or laparoscopic procedures. Hernioplasty. There are two methods. One is anterior open approach, Liechtenstein tension-free hernioplasty using only mesh placement is the most popular method. Number 2, posterior laparoscopic. TEP and TAP are the well-established procedures, but need thorough knowledge of anterior abdominal wall from posterior aspect. Thus, a long learning curve and technical skill is needed. No doubt, laparoscopic procedures have many advantages, but expensive, though less than robotic surgery. Whenever a mesh is used, preferably it should be large pore, low weight and monofilament. Most commonly used mesh is polypropylene known as Prolene. There are two special circumstances. Number 1, recurrent inguinal hernia. General principle to be followed is don't use the initial method of repair again. If the initial procedure was open repair, now use laparoscopic procedure and vice versa. The idea being use a territory not scarred by previous surgery. Second situation is management of sliding inguinal hernia. If recognized at operation, don't try to separate the bowel or bladder from the sac blindly. It will damage the involved viscera, leading to increased mortality and morbidity. There are certain methods of dealing with the affected viscera. Once reduced safely into the peritoneal cavity, Liechtenstein meshed herniaplasty is the preferred procedure. Alternatively, laparoscopic repair can be done if planned well preoperatively. Conclusion: there are several methods to manage an indirect hernia. The final choice depends on patient's condition, type of hernia, facilities available, economical status, experience and skill of the treating surgeon. The main concern is prevention of recurrence and chronic inguinal hernia. It is not just treating hernia. No doubt mesh is a big leap in the management of hernia, but it is not the final answer. In this respect, disorder repair is a most promising advance in understanding the mechanism and treatment of inguinal hernia. Next in the series will be question on femoral hernia. Stay tuned and subscribe. MCQs will follow.